Good morning. This is Dr. Tharini from the Department of Ophthalmology. Today I'll be discussing a topic on conjunctiva. So as we all know, conjunctiva is a transparent structure. It plays a critical role in maintaining the ocular health. Understanding the anatomy is essential for diagnosing and managing the ocular surface diseases. So this is a picture showing the conjunctiva covering the sclera and the lids. So definition of conjunctiva. So conjunctiva is a thin, transparent mucous membrane. So it covers the posterior surface of the eyelids, anterior surface of sclera up to the limbus. The parts of conjunctiva include palpebral part, bulbar part, and fornices. The palpebral part again we can divide it into marginal part, tarsal part. Bulbar part is again divided into scleral part and limbal part. Fornices are again classified into superior, inferior, medial, and lateral fornices. So this is the part of conjunctiva. So the palpebral conjunctiva lines the posterior surface of the eyelids. Fornical conjunctiva forms the conjunctival sac, and bulbar conjunctiva covers the anterior sclera. So this picture shows palpebral conjunctiva. This is the bulbar conjunctiva covering the sclera, and in between is the fornix. So palpebral conjunctiva. So I told you the palpebral conjunctiva has three parts: marginal part, tarsal part, and one more part is orbital part. So this is the cut section of the eyelid. If you see in this cut section, we can see the tarsal plate. And this is the lid margin. So marginal conjunctiva extends from lid margin up to 2 millimeter on the back of the lid up to a shallow groove called sulcus subtarsalis. In this picture, if you see only this 2 millimeter around this area is the marginal part of the conjunctiva. The remaining part is the tarsal part of the conjunctiva. It is firmly adherent to the whole tarsal plate in the upper lid. The lower lid it is adherent only to half width of the tarsals. Then comes the orbital part, which lies loose between the tarsal plate and the fornix. So orbital part is very deep. We cannot visualize it in this picture. Then comes the bulbar conjunctiva. So it is a loose structure covering the sclera, but it can be moved easily. It is separated from the anterior sclera by episcleral tissue and Tenon's capsule. A 3 millimeter ridge of bulbar conjunctiva around the cornea is called limbal conjunctiva. So in the area of limbus, the conjunctiva, Tenon's capsule, episcleral tissue, all are fused into a dense tissue which is strongly adhering to the underlying corneoscleral junction. So at the limbus, the epithelium of conjunctiva becomes continuous with that of the cornea. So again, this picture depicts the parts of all the conjunctiva. So bulbar conjunctiva has limbal part as well as the scleral part, and this is the fornical conjunctiva. Here, if you see, and this is the palpebral conjunctiva, which is again divided into marginal part, tarsal part, and orbital part. So the fornical conjunctiva joins the bulbar conjunctiva with the palpebral conjunctiva. It is divided into superior, inferior, medial, and lateral parts. Again, we have to know about two more structures. One is caruncle and another one is plica semilunaris. Caruncle is a small ovoid pinkish mass which is medial to the plica semilunaris, and plica semilunaris is a pinkish crescent-shaped fold of the conjunctiva in the medial canthus. Okay, so this picture shows caruncle and this is plica semilunaris. This plica semilunaris represents nictitating membrane of the lower eyelids. Then we're going to discuss about the layers of conjunctiva. So layers of conjunctiva, it has two layers. One is epithelium and the second one is substantia propria or stroma. So this is the epithelium, this is the stromal part. Coming to the epithelium, so the conjunctiva is lined by stratified columnar epithelium and they have goblet cells in between. The goblet cells are responsible for production of mucin, which is the key component of the tear film. So conjunctiva has the epithelium of the conjunctiva. The layers are not uniform. It is different in each part of the conjunctiva. So marginal conjunctiva has 5 layers. Tarsal conjunctiva has 2 layers. Cornicial conjunctiva and bulbar conjunctiva has 3 layers. And limbal conjunctiva has 5 to 6 layers. So at the limbal conjunctiva, the transition happens into stratified columnar to stratified squamous epithelium of the cornea. One more thing is the limbal basal epithelial cells have limbal stem cells. So the limbal stem cells are responsible for regeneration of the epithelium, regeneration of the corneal epithelium. The second part is substantia propria. It is a vascularized connective tissue. So this has two layers. One is adenoid layer. The second layer is the fibrous layer. So adenoid layer contains lymphocytes. The fibrous layer contains collagen, which provides structural support to the conjunctiva. Also, it contains blood vessels and lymphatics. And if you see carefully in this picture, there are these purple colored things or goblet cells, which are situated in between the epithelium. Vascular supply of conjunctiva. So the palpebral conjunctiva and fornices are supplied by peripheral marginal arterial arcades of the eyelids. Bulbar conjunctiva is supplied by posterior conjunctival arteries and anterior ciliary artery. Venous drainage is by venous plexus of eyelids and anterior ciliary veins. The nerve supply of conjunctiva is by trigeminal nerve. So the two ophthalmic and maxillary divisions of trigeminal nerve. Lymphatic drainage. Superficial plexus drains into preauricular lymph nodes and deep plexus drains into submandibular lymph nodes. Microbiology. Conjunctiva is never free of organisms, but the factors preventing the bacterial propagation include relatively low temperature, evaporation of lacrimal fluid, moderate blood supply, and tears are not a good culture medium. When we bandage the eyes, it raises the temperature and arrests the movement of the lids, and that can increase the bacterial content. The normal flora in the conjunctiva include staph epidermidis, diphtheroids, propionibacterium acne, Neisseria, corneobacterium xerosis, and viruses include herpes virus and adenovirus. What is the clinical importance of conjunctiva? The conjunctiva protects against infection and it supports the immune defense of the ocular surface because it contains lymphocytes. So this is about the anatomy of conjunctiva. Now we should know about conjunctival diseases. So what are the clinical features of certain conjunctival diseases? Whenever there is a disease in the conjunctiva, these are the common presenting clinical picture. The patient might have redness, stickiness, foreign body sensation, lacrimation, occasional photophobia, but vision is usually normal. Vision will get affected only when there is a corneal involvement. So first we'll discuss about the symptom of red eye. So red eye, there are a lot of causes of red eye. One of the causes conjunctival infection or inflammation. Other causes include that when there is a problem with the cornea, sclera, iris, ciliary body, anterior chamber, eyelid, orbit, everything will present with red eye. So what are the causes of red eye? So whenever conjunctiva, it is due to conjunctivitis, dry eye, pterygium, subconjunctival hemorrhage, trauma, and cornea, it may be due to abrasions, foreign body, laceration, corneal ulcer, keratitis, contact lens wear. Sclera, usually due to episcleritis or scleritis. Iris and ciliary body, it is due to iritis or iridocyclitis. Anterior chamber, it is due to hyphema or acute anticlosure glaucoma. Eyelid, the problems include trichiasis, ectropion, and ectropion, orbital cellulitis, and acute babesiocystitis. This is a picture showing acute congestive anticlosure glaucoma. The signs include a dilated, non-reactive, vertically oval pupil, shallow anterior chamber, and gonioscopy shows complete angle closure. So these patients also will present with red eye, but they will have severe pain and defective vision also. Episcleritis and scleritis. So this is a picture showing episcleritis and this is a picture showing scleritis. So you should know the difference between both episcleritis and scleritis. So episcleritis is inflammation of superficial vascular plexus, whereas scleritis is inflammation of superficial and deep vascular plexus. So in episcleritis, there only will be mild pain, whereas in scleritis, it will be severe and deep boring pain. The signs of episcleritis include a localized or sectoral injection, whereas scleritis includes a deep injection, and there might be scleral thinning, chemosis, and anterior chamber reaction. So episcleritis is classified into nodular or diffuse episcleritis, whereas scleritis is large anterior scleritis, diffuse or nodular, or necrotizing and posterior scleritis. So the nodule in episcleritis is small, mobile, and non-tender, whereas this nodule in scleritis will be large, immobile, and tender. The associated systemic diseases, there won't be any associated systemic diseases in episcleritis, whereas in scleritis, usually it is associated with rheumatoid arthritis. In episcleritis, if you put a drop of 2.5% or 10% phenylephrine, the blanching will happen because it is only superficial vascular plexus. Whereas in scleritis, if you put 2.5% drops, there will be no blanching. Complications or none in episcleritis, whereas scleritis can have complications like uveitis, glaucoma, choroidal folds, and retinal detachment. You do imaging, the scleral thickness will be normal in episcleritis, whereas the scleral thickness will be more in scleritis. The treatment of episcleritis include artificial tears and topical anti-inflammatories, whereas scleritis, the treatment is systemic treatment with corticosteroids, NSAIDs, or immunosuppressives. And this is a picture showing corneal ulcer. So see, there is a defect with infiltrate in the cornea. This also causes red eye. And this is a picture showing anterior uveitis. So if you see, there are keratic precipitates in the endothelium with posterior synechiae. So again, I have summarized the differential diagnosis of a red eye. So in conjunctivitis, the hyperemia will be diffuse and more prominent towards the fornices, whereas in episcleritis, the hyperemia will be focal. Scleritis, it can be either focal or diffuse, and in angle closure glaucoma, it is diffuse, more prominent at the limbus. And acute anterior uveitis, it is a circumcorneal injection of the conjunctiva. In keratitis, the condition is diffuse. Discharge will be present only in conjunctivitis and rarely in superficial keratitis, but other conditions will not have any discharge. Pupil will be affected only in angle closure glaucoma. The pupil will be dilated and non-reacting to light. Whereas in anterior uveitis and keratitis, the pupil will be constricted. So other conditions, pupil will not be affected. Pain will be very moderate to severe only in two conditions, which is scleritis and angle closure glaucoma, as well as keratitis. So other conditions, conjunctivitis, there won't be any pain. Episcleritis, there can be mild to moderate pain, and anterior uveitis only moderate pain. And vision will be affected only in angle closure glaucoma. It will be severely reduced, and anterior uveitis will be moderately reduced, and superficial keratitis, it is moderate to severely reduced. Cornea is clear in these two conditions. Cornea will be hazy only in angle closure glaucoma and acute anterior uveitis. So this is a picture showing conjunctivitis. Conjunctivitis is inflammation of conjunctiva. So it is characterized by redness and discharge. The etiology of conjunctivitis, we have infective and non-infective etiologies. Infective etiology, we have viral infections like adenovirus, measles, varicella, HSV and HZV, chlamydial inflammations, trachoma and inclusion conjunctivitis, bacterial infections like staph, streptococcus, gonococcus, tuberculosis, syphilis, and leprosy. Fungal infections can cause candidal conjunctivitis. Non-infective causes are allergic, which can be seasonal, perennial, vernal or spring catarrh, or atopic. Chemical conjunctivitis caused by acids or alkalis, and other conditions include keratoconjunctivitis sicca and caterpillar hair. So coming to viral conjunctivitis. So viral conjunctivitis can be caused by adenovirus, herpes simplex, herpes zoster, molluscum contagiosum, pox virus, myxovirus, paramyxovirus, and arbovirus conjunctivitis. Adenoviral conjunctivitis is the commonest cause of viral conjunctivitis. Adenovirus is a non-enveloped double-stranded DNA virus which replicates within the nucleus of the host cells. The general reservoir is only human. So the types of adenoviral conjunctivitis include epidemic keratoconjunctivitis, pharyngoconjunctival fever, non-specific acute follicular conjunctivitis, and chronic relapsing adenoviral conjunctivitis. Coming to epidemic keratoconjunctivitis, it is a type of acute follicular conjunctivitis mostly associated with superficial punctate keratitis, and it occurs in epidemics. So it is caused by adenovirus type 8 and 19. Incubation period after infection is 8 days. The viral is shed from the inflamed eye for 2 to 3 weeks. The symptoms include redness of sudden onset with watering, usually profuse, with mild mucoid discharge, ocular discomfort and foreign body sensation, mild photophobia, becomes marked when the cornea gets involved. The signs of epidemic conjunctivitis, conjunctiva congestion will be present, chemosis will be present, follicles will be present in the lower fornix and palpebral conjunctiva, papillary reaction can be there, petechial hemorrhages can be there, subconjunctival hemorrhages can be there, and there can be a pseudomembrane lining the conjunctiva. So this is a picture showing pseudomembrane. This is chemosis, and this is subconjunctival hemorrhage. So cornea can have epithelial microcysts and superficial punctate keratitis, and they are also present with preauricular lymphadenopathy. The treatment is mostly supportive treatment for amelioration of symptoms, and treatment is required. It includes cold compresses, sunglasses to decrease the glare, decongestant and lubricant tears to decrease the discomfort, and topical antibiotics to prevent superadded bacterial infections. Prevention of spread of infection to the contacts is very important. So since this is highly contagious and patients may be infectious for up to 11 days even after the onset. The transmission usually occurs from eyes to fingers to eyes and through tonometers, contact lenses and eye drops. Then next type is non-specific acute follicular conjunctivitis. It is the most common form of acute follicular conjunctivitis. It is caused by adenovirus serotypes 1 to 11 and 19. It is a milder form of follicular conjunctivitis. Treatment is similar to epidemic keratoconjunctivitis. Pharyngoconjunctival fever. Adenoviral infection is commonly associated with subtypes 3 and 7 will cause pharyngoconjunctival fever. So the pharyngoconjunctival fever primarily affects children. It appears in epidemic form. Treatment is similar to epidemic keratoconjunctivitis. The clinical features include acute follicular conjunctivitis associated with pharyngitis, fever, and preauricular lymphadenopathy. Cornea can have superficial punctate keratitis in 30% of the patients. Acute herpetic conjunctivitis is always accompanied by a primary herpetic infection. So this occurs mainly in children and adolescents. It is caused by herpes simplex virus type 1. And HSV type 2 is usually associated with genital infections that may also involve the eyes in adults as well as children, but it is very rare. The clinical features of acute herpetic infection include usually it is unilateral. It can occur in two forms. The typical form is follicular conjunctivitis, and it may be associated with a vesicular lesion in face and lids. Atypical form, the follicular conjunctivitis without any lesion in the face or eyelid. The condition resembles epidemic keratoconjunctivitis, but may evolve through phases of non-specific hyperemia, follicular hyperplasia, and pseudomembrane formation. Preauricular lymphadenopathy always occurs. So the treatment is usually self-limiting. So this, if you see this picture, this is the herpetic vesicles along with herpetic conjunctivitis. So this is usually self-limiting. We give topical antiviral drugs to control the infection effectively and prevent recurrences, and supportive measures are similar to epidemic keratoconjunctivitis. The another condition is acute hemorrhagic conjunctivitis. So this presents with multiple conjunctival hemorrhages, conjunctival hyperemia, and mild follicular hyperplasia. Usually it is caused by picornaviruses, that is enterovirus type 70. It is very contagious and transmitted by direct hand-to-eye contact. The incubation period is 1 to 2 days. The symptoms include pain, redness, watering, mild photophobia, blurring of vision, and lid swelling. Signs include conjunctival congestion, chemosis, multiple hemorrhages in the bulbar conjunctiva, mild follicular hyperplasia, lid edema, preauricular lymphadenopathy, and corneal signs include fine epithelial keratitis. The treatment is prophylactic measures are similar to epidemic keratoconjunctivitis. We give broad spectrum antibiotic eye drops to prevent superadded bacterial infection. Usually the disease is self-limiting, course is for only 7 days, and supportive measure is same as epidemic conjunctivitis. Another type is molluscum contagiosum conjunctivitis. So if you see this picture, the molluscum contagiosum conjunctivitis usually presents with waxy umbilicated eyelid nodule. It may be multiple and ipsilateral chronic mucoid discharge and follicular conjunctivitis. So treatment is first we can give destruction of the eyelid lesion. Then comes flictonular conjunctivitis. It is a nodular inflammation of the cornea or conjunctiva resulting from hypersensitivity reaction to a foreign antigen. So antigens of Staph aureus and Mycobacterium tuberculosis can cause this condition. Clinical presentation. So the conjunctival lesions may be only mild, they cause only mild to moderate irritation of the eye. Flictons can occur anywhere on the conjunctiva, but more common in the interpalpebral fissure, and frequently they are noted along the limbar region. They commonly present with a gelatinous nodular lesion with marked injection of the surrounding conjunctival vessels. The lesions may show some degree of ulceration and staining with fluorescence. They progress. Corneal flictonules similarly begin along the limbal region and frequently degenerate to corneal ulceration and neovascularization. In some instances, the flictonule may progress across the corneal surface due to repeated episodes of inflammation along the central edge of the lesion. These marching flictonules demonstrate an elevated leading edge trailed by a leash of vessels. Diagnosis is by history, clinical examination. Underlying infectious etiology requires further investigation. Chest X-ray, purified protein derivative skin testing, or quantiferon gold. For patients suspected of having chlamydia, immunofluorescent antibody testing and PCR of conjunctival swabs provide quick and accurate screening. Treatment is with topical steroids, topical cyclosporin, treating the associated blepharitis or underlying infectious flare. Chlamydia, we have to treat, if we suspect chlamydia or if we prove chlamydia organism is present, then we have to start on azithromycin or doxycycline. And if TB is suspected, then we start on anti-tubercular treatment. Then comes membranous and pseudomembranous conjunctivitis. So this can be unilateral or bilateral conjunctivitis. Pseudomembrane or fibrinous membrane can occur either in the palpebral or bulbar conjunctiva. It is made of fibrinous exudate that may or may not be firmly adherent to the epithelium of the conjunctiva. This is a picture showing pseudomembrane, and this is a true membranous conjunctiva. So pseudomembrane, if we try to peel off the membrane, it will come off easily, whereas in membranous conjunctiva, it is strongly adherent to the underlying surface, and when we try to peel it off, it will bleed. Causes of membranous conjunctivitis. Bacterial causes include Corynebacterium diphtheriae, beta hemolytic streptococci, Streptococcus pneumoniae, Neisseria gonorrhoeae, Staph aureus, E. coli, chemical and thermal burns, and viral causes. Diphtheritic infection chiefly occurs in children who are not immunized. Streptococcal conjunctivitis occurs in children associated with measles, scarlet fever, whooping cough, and influenza. Clinical presentation, mild cases, they can have swelling of lids with mucopurulent or sanguineous discharge. On averting the lid, palpebral conjunctiva is seen to be covered by a peelable white membrane. Then it is called pseudomembranous conjunctivitis. Severe cases, the lids will be brawny or hefty. Conjunctiva can have semi-solid exudates which impair the mobility and prevent formation of free discharge, and it compresses the vessels and tend to necrotize the cornea and underlying conjunctiva. Membrane separates less easily and may tend to bleed, then it is called membranous conjunctivitis. The treatment, we have to start on mild steroid and an antibiotic combination, topical 10,000 units per ml drop of penicillin from injectable solution, and systemic administration of penicillin along with anti-diphtheritic serum, 4,000 to 10,000 units repeated 12 hourly. In other bacterial causes, we have to start on antibiotic drops, and if cornea is involved, or any uveitis is there, then we have to give cycloplegics. Then, one other important condition is ophthalmia neonatal. The features of ophthalmia neonatal, this disease is still prevalent as a public health problem in conditions of poor hygiene and limited access to healthcare. It is severe because at birth, this is a condition happening in children at birth. So it is severe. Usually it is severe because at birth there is no tears and there is absence of lymphoid tissue, and the conjunctival epithelium also is thin and delicate. That's why it's very severe in children presenting with ophthalmia neonatal. The causative organisms include chlamydia, streptococcus, Neisseria gonorrhoeae, staphylococci, gram-negative coliforms, herpes simplex virus, and chemical causes. So, bacteriological examination is mandatory in each and every case presenting with ophthalmia neonatal. The differential diagnosis include watering due to a nasolacrimal duct block or congenital glaucoma. Neisseria gonorrhoeae manifest earliest. So within 48 hours of presentation, within 48 hours of birth, if the child presents with conjunctivitis, usually it is due to Neisseria gonorrhoeae. It is a virulent strain causing mucopurulent or purulent discharge. Both eyes are involved, but they are asymmetrically involved. Thick yellowish pus will be seen and marked chemosis will be seen. During examination, the surgeon must wear protective goggles and use lid retractors. So this is a picture how they examine a gonococcal conjunctivitis. They are using lid retractors to examine, and the child is having yellowish discharge. Cornea is seen buried in the conjunctival pit. There will be dense infiltration of the bulbar conjunctiva and tense lids. Later, the lids become soft and more easily averted. Conjunctiva is puckered with intense congestion. Pseudomembranes can be seen in the fornices. So this is again the same picture. Here can you see the pseudomembranes? Gonococcus can also invade the normal cornea, and there is a risk of corneal ulceration also if left untreated. Occasionally, it can also lead to perforation. Ulceration usually occurs in the oval area just below the center of cornea, corresponding to the position of the lid margin when the eyes are closed and rotated upwards. Sudden perforation with extrusion of contents can also occur. Then comes chlamydia trachomatis inclusion conjunctivitis. Manifests relatively late, which means after a week after birth. So when a child presents after a week of birth, then we should think of chlamydia as the cause of conjunctivitis. So this is a relatively common cause of ophthalmia neonatal. Bacteriological examination is usually negative. So the characteristic intracellular inclusion bodies are seen. Follicles develop after 3 months of age. Complicating superficial keratitis is a rule. If untreated, chlamydia, otitis, and pneumonia may also develop later. Other infections, other bacteria usually manifest 48 to 72 hours after birth. Herpes simplex viral infection presents 5 to 7 days after birth. Chemical toxicity used to be seen. Then comes chemical conjunctivitis. Usually it was seen previously. They used to be seen within few hours of prophylactic. Previously, they were using prophylactic topical silver nitrate solution 1% instilled into the eye of children. It was called Creeves method. So then they stopped using it. Now it has been replaced by erythromycin and tetracycline. So chemical conjunctivitis is very rare nowadays. Well, I am summarizing it. So within 48 hours, when you see a child with conjunctivitis present after birth of within 48 hours, then you have to think of gonococcal conjunctivitis or chemical conjunctivitis. The treatment for gonococcal conjunctivitis is IM injection of ceftriaxone, gentamicin eye drops, and bezitracin eye ointment. Chemical conjunctivitis, you have to wash the eyes and apply erythromycin ointment. 48 to 72 hours, we can think of other bacteria. So we again start on gentamicin or tobramycin eye drops. And 5 to 7 days, HSV virus. So we start aceclofenac 3%. More than a week, we have to think of chlamydia trachomatis. The treatment is with erythromycin eye ointment. Again, so this is about the diseases which we discussed about the diseases of the conjunctiva. So we have discussed about red eye and the diseases like conjunctivitis, everything. So now, what are the diagnostic techniques available for conjunctiva? So how we can examine the conjunctiva? So with torchlight, other than that, we can do a slit lamp examination. Then we can do a staining, whiter staining with fluorescent or rose bengal, and then finally conjunctival impression cytology. This is a picture showing ocular staining. So where we do a fluorescent staining in the eye, and we put a cobalt blue filter and see the fluorescent staining. This is a picture showing rose Bengal staining, where there are red cells, mucus plugs, filaments, and red-free filter. We use the red-free filter to visualize this. And this is a picture showing a lissaman green stain. Usually it is less irritant compared to other stains. And imaging of the conjunctiva. We can image the conjunctiva through an anterior segment OCT and a conjunctival photograph. So how are we going to manage all this conjunctival disease? We already discussed the conjunctivitis is caused by if there is a conjunctivitis, we start on antibiotics. If any infection is there, we have to start on antibiotics. If any allergy is there, then we go for antihistamines and mast cell stabilizers. And surgical intervention is done for tumor or degenerative changes. And what is the role of nutrition in the ocular surface health? So omega-3 fatty acids, they promote the meibomian gland function. So the best sources of omega-3 fatty acids include certain types of fish, ground flax seeds, walnuts, and peas. Antioxidants, oral antioxidants can, supplementary oral oxidants can also support tear production. So to summarize, conjunctiva as well as the tear film, they play a vital role in maintaining the integrity and function of the ocular surface. So their understanding of the anatomy helps in diagnosis and management of various ocular conditions. So I'll revise whatever has been completed. So I'll revise it once again. So today we discussed about conjunctiva. So what is conjunctiva? What are the parts of the conjunctiva? So we have conjunctiva is a transparent membrane. It has palpebral part, bulbar part, and cornicial part. So this is a picture showing bulbar part, cornicial part, and palpebral conjunctival part. And we have caruncle and plica lunaris. And then we discussed about the layers of conjunctiva. This includes epithelium and substantia propria, how the epithelium layers are different in each part of the conjunctiva. And this is substantia propria. We discussed about two layers, adenoid layer and fibrous layer. And what is the vascular supply of the conjunctiva? So the conjunctiva lining the eyelids, they get the supply from the eyelids itself. Conjunctiva lining the sclera gets supply from the conjunctival arteries and ciliary arteries. Nerve supplies from ophthalmic and maxillary divisions, trigeminal nerve, lymphatic drainage into preauricular and submandibular nodes. Then we discussed about the normal flora of the conjunctiva. Then we went to discuss about the red eye. What are the differential diagnosis of red eye? So we had congestive glaucoma, episcleritis, scleritis, corneal ulcer, and anterior uveitis. And how each one is different from each. So we discussed the clinical presentation of each condition. Then we discussed about conjunctivitis. So we had infective and non-infective conjunctivitis. So today we discussed about infective conjunctivitis. So this is a picture of viral conjunctivitis. Commonly, which we see is adenoviral conjunctivitis. So we have epidemic keratoconjunctivitis. So how it presented. Then we had follicular conjunctivitis. Then we had pharyngoconjunctival fever, herpetic conjunctivitis, hemorrhagic conjunctivitis, and molluscum contagiosum conjunctivitis, plictonular conjunctivitis, which is due to hypersensitivity reaction to the infective agent, membranous and pseudomembranous conjunctivitis. Then we discussed about ophthalmia neonatorum, which is a conjunctivitis seen in immediate postnatal period of a child. So this we discussed about how to examine a case of ophthalmia neonatorum and how it presents. So we had a summary of all these things. So if the child presents within 48 hours, then the cause is neisseria gonorrhoeae or chemical conjunctivitis. If the child presents within 48 to 72 hours, then it should be due to other bacteria. And if it is 5 to 7 days, then we have to think of herpes simplex. More than a week, then we have to think of chlamydia trachomatis. And the treatment differs for each condition. So what if don't treat abdomen in utero, then the child can go for corneal perforation also. So it's very important to treat early the gonococcal conjunctivitis for any other ophthalmic interim condition. And how we diagnose how we are going to examine the conjunctiva. We can use a slit lamp or a vital stains we can use to stain the conjunctiva. Then we can do the imaging part, and finally, how we manage the conjunctival diseases and how to promote the conjunctival health. So we can provide nutrition. This is the summary. Thank you.